Good morning. We were just kind of laughing over here, but we're talking about, we know this information inside and out, but actually it's been 3 years since we've actually seen people face to face, so it's a little intimidating. I've seen people on the screen before, but it's good to see you all here, and thank you for coming and participating in this. Now, I'm just the warm-up act, so you're going to see some of the slides that I'm presenting. You'll see them again as David goes into more detail, especially as he talks about the acquisition process, contracting, and things from the industry perspective. But I'm going to start with just a general overview, talk about the stockpile, a little bit how we've evolved. And there really were about 4, I think, periods across the existence of the Strategic National Stockpile where it's really been something that's changed how we do business and how we respond as a nation to get us to where we're at today with this collaboration with industry. So just a little bit about me, and this is going to come back to haunt me. So I'm going to say it. So I'm a former helicopter pilot in the Army. Remember that. It's going to come back to haunt us. And I was a medical service corps, so I did commanded field hospital units. When I wasn't doing that, I flew helicopters. It's going to come back, I promise you. It's not in a good way, by the way. And then I was lucky enough to come on to the CDC after a stint with Seattle-King County in their public health. So now I'm a lead public health advisor. I am the person responsible for industry engagement and outreach. So as far as partnership goes, please reach out to me. I've got some business cards up here in the front. Take that. But if it's money-related acquisitions, David Kelly, go to that group over there, okay? Okay, so we'll talk about the stockpile, supply chain integration. Really want to talk about lessons learned, and I'm even going to lean in a little bit about probably 2023 and some of our initiatives and things we want to do, because that involves you. We've realized that we are so much better together. The stockpile is not the sole answer for everything. There is no way you can stockpile yourself out of every emergency that could possibly exist, right? So we can't do it without you. So looking at those initiatives and key takeaways, and then just a couple discussion items as we move through this. We have to start with ASPR's Key Priorities. So of course, number 1, we don't want to let go of the capabilities that we have developed and how we've responded to COVID-19. And when I say that, this is the first time that I think we've done a little bit, and I say just a little bit of collaborative planning with industry, whereas in the past we've done a collaborative response, but we see that this collaborative planning is going to be more and more important as we move forward. Now, along with that, we've got a lot of initiatives, a lot of things that hopefully within 2023 we'll be able to share and do together. So hopefully I am gaining some of your interest, and let's see what comes out of that. Number 2, restoring the resources within the stockpile. What we've done here is, as we've, of course, responded, we've had to resupply the stockpile. That was something that was a challenge after H1N1, but it's something that we have been doing and will continue to do for the foreseeable future with the stockpile. And of course, that's number 3, which is prepare for the future. The ASPR mission, I'll give you a minute to just take a look at that. And here's our current organizational structure. So we're just fortunate enough to hear from our director, Steve Adams. With our 6 branches on the bottom, I will say that the 6th branch, and that is David Kelly, the man with the beard here in the corner, is our newest branch chief. Acquisitions branch is something we realize that contracting and acquisition is really critical to how we respond, and it gives us a lot more capability as we go out and maximize your capabilities all the way down to your relationships, your systems, and everything to get product out on the street. So if we were to talk about things such as responding through pharmacy chains, there's a Walgreens and CVS on every street corner, right? So there's opportunity out there that we're continuing to look at. Plus, a lot of you already have established relationships either with the healthcare facilities or with those commercial partners. We're established in 1999 as the nation's pharmaceutical stockpile. That was, okay, get ready for this. We're going to find out, we're going to see who's old and who's not. I said old, that's not the right word, but the reason that we were established in 1999 was Y2K. You guys know what Y2K is? Yes, no? See how we got some youngsters up here. Y2K. So believe it or not, I'm going to talk to you. So believe it or not, in 2000, all the computers were based off of a 2-digit year, right? So 99. No one knew what was going to happen when everything rolled over to 00. We thought it was going to be the end of the world. All the computers were going to shut down. no cell phones or anything. So as part of that, they decided to put $51 million into pharmaceuticals in case there was some kind of an issue where we had to respond. Started because of Y2K, who would have thought? We talked a little bit more, but we've come from that $51 million up to $13 billion in inventory. And along with that, we moved from what was first having that little supply for the stockpile for pharmaceuticals to becoming the nation's repository for medical countermeasures. And that first mission, that mission set was bioterrorism related. So if you have not heard about the Strategic National Stockpile, it's because we were kind of hush-hush for a long, long time because we were that bioterrorism response agency with those medical countermeasures. 2001, you may remember the anthrax letters that were being mailed out to some of our representatives. That was a big instigation to get us into that bioterrorism world. And then we move on to some emerging infectious disease. I'll go back to Ebola. You all remember that, how terrified people were there. I was in Liberia, Africa, fighting that battle. 11,000 dead, I want to say, over there. And I came back on, it was July 4th, and at that time we had 6 patients in the United States. And you remember how people lost their minds in the United States because it's scary. It's a scary, scary disease. So moving into that emerging infectious disease space, actually started in 2009 with H1N1. And then, of course, Ebola kind of tipped us over the edge, rolled into Zika. And of course, here we are now, natural disasters, hurricanes. We're continuing to respond to those with some beds and some other kits and outfits. So you can see our medical countermeasures at the bottom, primarily in that bioterrorism space, now moving to really support that emerging infectious disease, pandemic influenza, those things. And this is a list of our formularies as it stands. I'll talk a little bit later about how this is determined. I'll say this about 5 times, I think, throughout the presentation. We do not determine what goes in the stockpile. Okay, listen to what I'm saying. We do not determine what goes in the stockpile. We're the caretakers. And the reason that's important is there's a huge process to determine what goes in there. And we'll talk about it in probably a few more slides. But right now, this is our formulary. David's going to go into detail on this formulary. And with that, he's going to also kind of correlate some of those diseases, our prophylaxis, and then our treatment material that goes along with it. Now, some of that you're just never going to know. The bioterrorism side, we're not going to share that with you, simply because if you knew what countermeasures we had, you could design a threat around it, right? So that's why we're a little bit hesitant about sharing some of the items that we have. But the emerging infectious disease stuff, we're really focused on those 5 categories: gloves, gowns, masks, face shields, N95 respirators. That's something that's out there quite a bit. We'll share that with you. And also talk about how we use you all to help support that PPE. And I could probably, I don't want to ask, but we're going to talk about PPE and emerging infectious disease. I bet you every one of you out there probably has excess inventory right now, right? Yeah, we do too. So collaborative planning, right? We want to get back to that, how we can do that better at the end so we're all not left holding a lot of excess material. So who does what? I've had to do quite a few presentations on what the SNS is and is not. Let's start with BARDA. You're probably familiar with BARDA. BARDA's industry days, so Biomedical Advanced Research and Development Authority. So BARDA is our sister agency. We're all under the ASPR, HHS, right? BARDA will support that development of these medical countermeasures. And I'll leave this up for a minute as you read through it. So you see that BARDA will get these material countermeasures developed. We're looking for things from them such as longer shelf life, something that can be stored at room temperature, get us away from those ultra low cold storage requirements, things of that nature. As they do that, they also come back to us, and a lot of the stuff that they develop then gets put into the stockpile, and we'll maintain, and then we'll help push that out. And that's the first bullet, of course, under the SNS. We're here to maintain and deploy those medical countermeasures. Primarily, well, I'm not going to say primarily anymore. I don't think that's true. So for bioterrorism events, for emerging infectious disease, and I will even say that I think we have moved to an all hazards response posture instead of just trying to limit us to where we're at on these things. So if we've got material for it, I know that Steve generally gets asked by the ASPR and others, what do you have available? And of course, then they'll say deploy it. Rationale for stockpiling, and I'm sure you all understand this and you get it. First and foremost, a lot of the stuff we have around bioterrorism, there is no commercial market for it, right? You talk about the commercial market, profit-driven, just-in-time inventory. That really feeds into a lot of what you're seeing here, why we need to stockpile. So no commercial market for, large scale. You look at monkeypox, right? So we're talking about smallpox. If there was a smallpox outbreak, it's actually considered, historically, if there was a smallpox outbreak, for us, that becomes a push. And we'll talk about that in a minute. Because there's only two places in the world that there is a smallpox virus. That's in the United States lab and the lab in Russia. So if there's a smallpox outbreak, now it's that bioterrorism event that we're afraid of, and we're going to push. The commercial market doesn't have enough out there for smallpox to say, you need to take care of New York City in the next 48 hours, right? So it just is, and that's why we're here. That's what we're here for. So the quantities of it, the type of material, and then the commercial supply chain not being optimized to dispense, that gets back to, say, if I was to bring up an anthrax, right? If there was a crop duster, aerosolized anthrax, they spray across Atlanta, I need 18 million courses in people in the next 48 hours. Commercial market is not going to be able to do that. That's what we're there for. We send that stuff out in bulk and try to get pills to people as soon as possible. So we know that the commercial supply chain is broad. We also know it's shallow. We also have a lot of capacity and capability that we're trying to tap into. So as we move into 2023 in times of need, we're looking for you to be we're looking for us to be more inclusive, to use you as partners. And that's the supply chain integration. So we, of course, cannot cover every threat possible. As we move into COVID, I'll talk about this, I think, in another couple slides. I was trying to figure out where to put this. But we are strengthened by the commercial sector's capacity for distribution, for the relationships, the ordering systems, and even some of the data tracking. And I think data is where I'm going to get a lot of interest from you as we move forward into this presentation. So we are so much better together, and I'll just leave that as that tagline. Now, what I will say is this is what we first look like. I got two slides here. I think I want to show you kind of where we find ourselves and why I'm glad you're all here. So our legacy distribution. If you go back to the early 2000s, SNS to the state would then take the material we dropped off by the truckload, they would push it out to that point of use, right? That's where we have come from starting in 1999. This is the last year, and where we feel like we're at now. Help? A little change for us, right? So now that we see that the industry is capable, you're engaged, you're out there, we find that we are now better positioned to collaborative planning, right? So was that number 2? Number 3? Collaborative planning to work with you all to make sure that we fit within this system. We need to be, and we want to be, the buffer for the commercial supply chain. We realize we can't be all things, but what we can do, working with our partners on these high threat scenarios, we can determine what we need to hold in the stockpile to be a buffer as the commercial supply chain ramps up to meet that demand. So that's the golden end state, right? Is for us to know what we actually have to hold while manufacturing increases and distribution capacity increases through you all to handle the event. So notice on here we've got industry, but we also have the federal government. We've got a lot of people who have to take over there, a lot of partners, and of course the state, tribal, local, and territorial governments. And we've even done donations. When I say we, the federal government, 180 million different courses of COVID vaccine to over 100 different countries over the last probably 2.5 years. So as you can see, we're pretty busy, and have been for about 3 years now. Well, I should say 10. So this is where I want to bring back being a helicopter pilot, right? So working with our commercial partners, I get to go out, I get to speak, I get to do these engagement pieces. And one of the large healthcare systems that is in North Carolina, the first thing they said about why they haven't collaborated with the stockpile was they're afraid the black helicopter is going to fly in and find out if they've got a stockpile, come in and take it, and fly it away in their helicopters. Now imagine my shock after I just said, hey, I was a former helicopter pilot. Oh yeah, you're that helicopter pilot I was talking about, and the federal government's going to fly in and take my stuff. Steve won't buy me a helicopter, so I can't do that. But what have we learned? Well, I'll just start at the very top, kind of that 11:30, 12 o'clock position. Kind competition, right? Did we, and I see some of you shaking it, yeah. This is the first time that I've seen a large-scale use of the Defense Production Act, which means the federal government's going to get theirs filled before you all, right? Oh, look at all the heads. There's a lot of affirmatives going on. Competition for these supplies was ruthless. And it's kind of led to that better integration of data would have saved us a lot of heartache and a lot of heartburn. And what I mean by that is, and we're going to talk about the supply chain control tower. I want to say there's over 400 different industry partners that responded and participate in that. But what we did to do, or what we failed to do is we ramped up. We're probably a little late to really hitting a key indicator out to manufacturing saying, hey, something big's coming, ramp up. And then of course distributors, hang on to your shorts because we're gonna need X, Y, and Z for this type of response. And we're seeing, that's a huge area of opportunity for us, so we've got a lot of collaboration, a lot of people very interested. We do not want to lose this momentum with you all. So let me say it again, we don't want to lose this momentum with you. We want to continue to work this data integration piece. I'll share some slides on this in a little bit. And then also, I'll go down to the kind of the 3 o'clock position there. We kind of missed out on the coalitions, the healthcare coalitions, and the large hospital systems. That is not a place we have generally been in the past. When it comes to therapeutics and monkeypox, we actually did do some direct-to distribution, which is a little bit larger scale. We've done onesie twosies in the past, but as far as a large response goes, we haven't quite done that. And then I'm just going to get all the way back around to our formulary continues to evolve and change. David's going to talk about that, some of the financial implications to that, but I think it's important for you all to know at least some of the material we have and how we respond so you can be better prepared to do that yourself. Okay, so once again, we don't determine what goes in the stockpile. This is something that is done by the FEMC. You're going to hear FEMC quite a bit. That's the Public Health Medical Countermeasures Enterprise, led by the ASPR. So she will pull together, historically it's been large federal agencies such as DOD, the VA, CDC, working with her. And I know that they're also looking at adding in more commercial partners and also adding in some of our state and local leadership as well to talk about what needs to be stored in those quantities. Now, so for that non-emergency process, that's something happens when they look at the national threat scenarios. They'll take a look at that. What's the right thing for the stockpile to have in its inventory to combat those national threat scenarios? And then they'll look at capacity, what's in the marketplace, and that helps determine what we need to then store. The emergency process is a little different. Supplemental funding, and David I think is going to hit on this a lot. A lot of this supplemental funding is where a lot of this new boom, we need to get 1 billion exam gloves, like now. Of course, what does that do? Hey, we're getting 1 billion exam gloves from China, and then you are like, I can't get my exam gloves, and my customers can't get it. So once again, I'm kind of teasing back that collaborative planning, so I'm the partnership guy. So we'll come back to that so we can work on that and do that together instead of just kind of all of a sudden people starting to see deliveries not being made. So here are our customer bases. Primarily, it's the states, right? And those jurisdictions within the United States. We do have some self-funded, I guess, large urban areas. So you can think of, LA, Chicago, New York City. So they do get some funding as well, and we do deal with them directly. And of course, the tribal nations. Those are our primary customers. The secondary customers, this is just a small list, but it gets even bigger. So we have our federal partners. We've got the general public, different entities that are out there. And this generally goes down to healthcare workers. A lot of times you'll hear some jurisdictions come back and be like, what about my PPE? What about my bus drivers? What about critical infrastructure? Those are discussions that are made and decisions made at a much higher level than me, but our customer base is broad. A lot of times DOD will come in and be like, we can do this. And I'm former DOD, so I'll just say that the problem with that is their customer base is about 1 million, right? 1 million soldiers and airmen and sailors. I get them all. Whereas our customer population base is 330 million, right? So imagine courses, doubling that 330 million for 2 courses. So once again, our customer base is large. So how do we deploy? Push and pull. I'll talk a little bit about pro rata, what that means. But the push method is kind of what I talked about. Say we get that smallpox, boom. Tampa Bay, all of a sudden smallpox everywhere, it's starting to expand. We know we've got to push everything out to it. We know it's something that should not be naturally occurring. The SNS is going to push all of our supplies down there to try to contain it as quickly as possible. Pool method, a little bit different. Pool method, the example on here is Zika. If you don't remember Zika, that was what, about 2016, I think. Started in Puerto Rico in the southern United States, where microcephaly, babies are being born with small heads, microcephaly. And so we got back to our old role of kind of mosquito control and medical countermeasures, also education. But that was a request from them for us to come in and support. So that's what we mean by push versus pull. Make sense? Easy enough, right? So what is pro rata? Pro rata is basically, we will give you the percentage of our holdings that matches the percentage of your population. Make sense? Yeah, so it's simply a numbers game where, you know, Montana's got a certain kind of allocation in the back of our heads. Now, I gotta be careful with this because just because I say an allocation, you know, in our minds, we're breaking out our inventory kind of by population, so you're gonna get that equivalent percentage. I will say that we do generally pull 10% back to hit the hot spots. So if there's gotta be a surge or something like that, we will generally have just a little excess standing by. But also, you know, it's never locked in stone. We really try to follow the science, follow the data, follow those outbreaks, and try to make sure we put that product where it goes. But that's what pro rata means. When you hear that, it's more or less a population-based distribution. The last one I think you're really gonna like, tiering. You may remember back in Ebola, if you weren't a responder in Ebola, there's such a high demand for PPE, right, and droplet protection PPE. Just wasn't out there in large quantities that we needed to take care of these patients. So what we're able to do then is look for those healthcare systems that could handle that type of contagious patient, you know, in high flare, laminar airflow rooms, that level of protection needed, and designated them as kind of tier 1. Our distributors at that time were able to take that letter from us designating those facilities as tier 1. Okay, don't get mad. They were able to kind of protect themselves because they took that and said, look, CDC, SNS is saying we got to make sure PPE goes here, and those contract deliverables they had for other healthcare systems, we're going to push you off for just a minute, right? So that is something that's in our tool bag still. It's not a policy. I wouldn't say it's even an official best practice right now, but it is something we've done in the past, and it's something that tends to work. So if we get another really contagious outbreak where we have to go back through and tier, you may see that again. Okay, so let's talk about data again. The supply chain control tower. Is anybody, just shake your head, anybody participating in the supply chain control tower right now? Got a few? So supply chain control tower, like I said, we had, I think David's number is 411 participants in the response, industry partners. Quite a few of them are providing data on a daily basis back to the supply chain control tower. That supply chain control tower is able to take that information, sanitize it, and then kind of push out an overarching report. And I'll show you what some of the reports and that decision-making from those reports look like in the next slide. But it really gave us that end-to-end visibility of where material is needed, where it's available, and that actually prevented quite a bit of stuff like former state and local as well, right? Seattle King County, hoarding, right? Everybody, and you all know this because you get these orders, something kicks off, everybody's putting in massive orders. I can't get it from you, I can't get it from McKesson, I'm going to Cardinal, put in the same order. I can't get it from Cardinal, I'm gonna go over here, you know. You've all seen that. This helps us kind of determine that there's plenty in the market, just put your original order in, and then kind of, let's just, you know, calm things down and talk from a statistics and data standpoint. So it allows us for that forecasting, that visibility, tells me we're going by helicopter. Did I lose you? No, you guys, no? Okay. Nobody, you're still with me though, right? I'm not, okay. Okay, so here are some of the reports and dashboards we're able to use with the supply chain control tower. If you're not a participant in that, we would love to invite you to participate. Terabytes of data. So situ awareness, of course, is out there. Our supply status, we're able to pull that information to make decisions based off of data. Information, you know, instead of just what our gut feeling is. It's really nice to be able to put it in front of the boss, statistics and data, showing exactly where stuff is at. And of course, those metrics help us track the disease burden. So you can actually watch it with these metrics. You can watch it flow across the country, where treatment's happening and where those supplies and shortages are at. Here are a few other things it allows us to do. It allows us to go all the way back in the supply chain. So whether it's a, you know, political unrest in a certain country, or dare I say a rail strike. If you haven't heard that one, get ready. So they're talking about that, the rail workers talking about the strike again. So ports being plugged up and congested. So all of that stuff and those critical supply chain nodes, we can see through this system. And it's really helped us do quite a bit around planning and how do we get around that and continue to move product. So this was the first slide I showed you. So our classic legacy modality, right? How do we distribute? Us, states push it out to your public health. We're growing. Now, the last couple responses, we've actually put supplies into the commercial system and let you all handle that from a private perspective, right? Those relationships, those systems, and you guys have a robust distribution capacity that, when we go out to get trucks, we're in competition. A lot of distributors have their own fleets and able to push things out. So us now going through the commercial supply chain, and of course, us now doing some direct to points of use. I'll say there's even a fourth on here. And it's not official yet, but if you talk about monkeypox and you talk about the therapeutics that we pushed out, we've even done some coordination where it's manufacturer direct to point of use, kind of at our direction, I guess, or those contracts. So I think we're going to line up maybe another mechanism, if not a fifth, moving forward. You heard the ASPR talk about this a little bit, the replenishment progress. So these are our goals. We're pretty much there. Now what I'll say about this is, as we go back to collaborative planning, there, I got it in. That's the third one, collaborative planning. I think one thing that we could have done here, and one thing we're talking about with our industry partners, we've got so much excess that's left out there in the supply chain. So if we had let's say we got a requirement for 1 billion N95 respirators. As we resupplied going throughout, maybe we should have stopped at 500 million, or maybe we should hold it during an incident at a certain number, whatever that's going to be, and use that data that's collected from the supply chain control tower, and then just maintain that supply that we think is adequate, knowing that there'll be excess in the commercial supply chain when this is all said and done. And then we can pull that out of the commercial supply chain, so you all haven't had to open up 15 extra warehouses. You all haven't had to hang on to excess that may or may not expire on the shelf, right? So that's my pitch to that external partnership piece. There's benefit. Sharing that information in the supply chain control tower, it's going to help us get there to something like that where it's a little more collaborative. So the key takeaways. The SNS is a buffer, a bridge. We know that we cannot be all things to all people. There's just not enough money. There's not enough warehouse space. There's no way we could do that alone, not for every event that you could possibly think of. So we don't define the requirements. That's the FMC process. You'll hear a little bit more about that. We are increasing in our scope of mission. That's both product and kind of the mission response set. So, I want to see it as a delineation now of emerging infectious disease. And then, of course, the more hush-hush bioterrorism response. And, of course, we're working to leverage the relationships with you all and our industry partners to do this at a much better, more efficient way, efficient rate. You can send a message through the industry portal to us, or if you want, you can hit us up with an email. We'll get those over to our communications team and we'll answer any questions that you have. Other than that, thank you all for your time and appreciate you being here this morning. Thank you.